some challenging situations that you might have clinically. So let me just make sure the screens are all clear. So let's start with composite, and feel free to, I guess, put some questions in the box or however it normally works, and then Kris and I will obviously take them as we go. And yeah, we'll take it from there. So in terms of kind of, I guess, composite, so we're going to try and obviously, you know, I guess cover as much as we can, but we don't want to, I guess, cover anything too briefly. So essentially it's going to be hopefully, you know, a little bit of a step-by-step, but let's start with something a little bit more complicated in terms of kind of composite restorations, and class 2s are what most people kind of, I guess, you know, have difficulty with for a number of different reasons. Main one being kind of matrix bands, which ones to pick for which scenario, and how to make sure that they're very well adapted to get a very good contact point and, you know, get the occlusion right and so on. But essentially there's two main types of matrix bands. There's loads obviously out there, but there's two main ones that I think people probably routinely use, which is the sectional, which is on the left hand side, and then obviously you've got the circumferential on the right hand side. And I think the first thing to really understand and appreciate about a matrix band is what you're using it for, which is essentially to kind of, you know, I guess, recreate your contact point and give you a very good contact profile, so that you don't get any food trapping. And there's obviously different ways to get there in the end anyway. So both have their places, and me personally, I use kind of, you know, both on a daily basis. Sometimes I use them together, which we may, I guess, you know, kind of go into at the end. But in terms of kind of the main differences between the two is the way that you get your sort of profile, which you can see from a bite wing after, and you can kind of see on the bottom left hand side, you know, a sectional matrix. It gives you more of a curved profile as opposed to something like a Toffel-Meyer or an omnimatrix or a circumferential matrix. And that, again, you know, it means you still have a contact point so the patient can floss. But if you look at the embrasure, so the embrasure is basically the triangular region beneath the contact point. One is going to be a lot tighter, or a lot kind of, I guess, shorter, which is the sectional one, because you've got a curved profile. And the other one, the Toffel-Meyer or the circumferential one, is going to be a lot straighter. So there's more chance for things like food packing. And that's kind of where, I guess, you know, myself, I pretty much, if I can, will always use a sectional matrix for that reason. Sometimes it's not possible, and we'll go through ways to overcome that in a few slides time. But the key is to try and basically, you know, I guess, adapt your matrix very well to get that tight contact and get that profile. Now, just before we move on to the next slide, I think you can see on the top left, just on my cursor there, sometimes when you put your ring, so that's the blue thing that you see on the screen there, when you put your ring against your matrix band, you can sometimes have a little bit of a gap just there. And that's usually because you've got a class 2 cavity. So you've removed some tooth substance, obviously because of caries or whatever else. That gap can obviously lead to an overhang, or it can lead to a bit of excess composite there. A good way to seal that is take a little bit of PTFE, which you can just see there, kind of scrunch it up into a ball and just pack it in with a probe or something kind of, you know, quite thin, like a flat plastic. And that will compress your matrix band against the tooth. So that way, when you actually pack your composite, this is rigid, there's no flash, no excess. And it also basically means that you have less to tidy up at the end. Again, we'll go through that in a few slides time. If anything's not clear, guys, feel free to kind of just, you know, drop a question or a message and whatnot. So again, looking at class 2 composites, you know, there's, like we said, there's so many different types of matrix bands and even types of sectional matrix bands with different, I guess, thicknesses. So like we said before, you know, we try and use as much as we can anyway, the sectional matrix. So that means that you have kind of 3 separate pieces, which is the wedge, the ring, and obviously the sectional actual kind of, you know, metal kidney bean shaped band. And you can kind of always, I guess, you know, work out which size is the best for the tooth. But if you have kind of, I guess, the V ring, which is the dent supply one, they come with loads of different sizes. And anyway, it's sometimes difficult to work out which one's right for which scenario. And sometimes you kind of, I guess, you know, just guess and work out if it works or not. Now, this is a really, really useful photo because it kind of gives you an idea of what sort of factors to take into account when you are working out which matrix is the right one for the right tooth shape and the right cavity. But the key is to make sure that the adaptation at the base of the tooth, and obviously your filling that's to be, is tight, and you're not too high on the occlusion. The reason is because when you start actually packing composite in, you build to the top or near the top of the band, right? And if, for example, you have a really large band, what tends to happen is you overbuild, so everything is off. So that means your marginal ridge is high. So that's basically meaning that the patient's going to bite down and it's going to be way, way too proud. Your obviously anatomy is going to be completely off because you've built to a completely different reference point. So you're going to have to cut that all down. And then you're going to end up with probably a flat composite, which, to be fair, is nothing wrong with it. It just means that, you know, I guess you can't post it on Instagram probably, but that's basically it.
But I just want to add in as well. Yeah, so it's really important, obviously, that your marginal ridge isn't too high. Also, because if you've got, if you look at the picture on the left of your screen, obviously it's nice and curved, that marginal ridge. But if you look at the bottom bit, that's quite unsupported. So it's always going to be unsupported, like filling essentially, where it curves upwards. So if you imagine biting down on that unsupported part of the ridge, it's going to be putting quite a lot of stress on that filling. It's going to fail a lot quicker. So you don't want any static, like when you're marking up your occlusion, you don't want any bite on that marginal ridge either. It's also quite a difficult area to adjust because it's between the teeth. So you can't get a burr in there nicely. And it's really difficult to adjust if that goes wrong.
Yeah, that's a really, really good point. What Kris is kind of mentioning is about stress points and where your occlusion is going to be high. If that's at the margin of the tooth and the composite, that's basically the worst point it can be, because obviously that's the join between the tooth and your filling. And if it's high there and the patient bites down over time, it's going to either crack, break, or whatever else in terms of fail. And it's obviously tough to adjust in that sense because you don't have the right, I guess, there is no ideal burr that I've found that can adjust in that space because of where it is and how close it is to the adjacent tooth. So yeah, I hope that makes sense. So what is the order of doing this in terms of, you know, I guess I always used to struggle when I was at uni, and, you know, it was difficult to work out what's the best order or what's the best way to do this. But essentially the metal matrix band is obviously the kidney shaped, I guess, you know, silver thing that you see on the screen. And then you've got the wedge, which are plastic, or you've got the wooden ones, or, you know, whichever you prefer. I tend to use the wooden ones, I'd say probably most routinely, but I tend to also kind of, you know, adapt and modify the wedges, which we'll go into in a second. And then the sectional ring comes at the end. So that's the general order that you want to do it in. And the reason for example, your sectional ring is to just put a little bit of pressure on the teeth so that you can get a very, very tight contact point at the end. And that's kind of how you do it. So in terms of general order, I'm sure probably most of you guys know this already. I just didn't for ages. I always just get confused. It's basically the actual kidney bean first, then the wedge, and then the sectional ring. That's what I think works well for me anyway. And like I said earlier, you can use things like PTFE, just where you see the white bit there. That's just to adjust and tuck that band in closer to the tooth so you don't have any excess. I think one of the biggest tips that I probably have learned over the time is try and always think one step ahead of whatever you're doing. So that means, let's say, for example, if you're building a class 2 composite, or, you know, whatever, like a crown prep or whatever, just always try and think one step ahead of what step you're at now, because you always want to kind of just make your life easier and quicker and efficient. So things like this PTFE thing, this PTFE tip, that's so useful because it means later on when I finish my composite, I don't have any excess there, so I don't need to adjust it. It just makes life easier. So try and kind of think in that way where you try and make your life easier for later. But yeah. So wedge position. So I'm guilty of having the, you know, having suffered from the incorrect photos that you see personally. So I've done this. I've probably done all the mistakes that you'll probably see in a bit. But the point is that I guess when I was learning about composite and stuff, I just pretty much thought, yeah, you just kind of use the band, you put a wedge in and you build it. And that was effectively it, and try and make it look half decent. The point is that you have to really understand what each step is for and what, you know, what the reason is behind it. So the reason that you haven't, you've got a wooden wedge or a plastic wedge in your matrix system, right, is to put tight cervical pressure. So cervical is obviously at the base of the tooth. You want to put really tight pressure around this point so your band is adapted really firmly against the tooth. So there is a really, really strong, tight seal there. So you don't have things like leakage, you don't have things like gaps and voids where, you know, you get secondary caries. And, you know, that's the main reason why you're doing it, right? Now, if you don't realize that, you end up with these two scenarios where you just choose any sized wedge that comes in your kit and you basically just, you know, put it in. Now, the issue with that is that you get the distortion of your matrix band. So that means if your wedge is way too high up, so it's not at the right point, it can actually cause your matrix band to go inwards. And therefore, when you know, I guess, let's say build your composite at the end, you're going to have a little ledge here, like you know, a negative ledge. So that means if you floss it, it's just not going to work. The patient's going to keep tearing the floss there. Now, again, same thing here. This is an indent. This is, you know, the wedge is way too thick. So that's why there's a little kink in the band. And that, again, is going to lead to problems later on because you're going to get things like food trapping or floss tearing and stuff. So think of it as your wedge and your band is like you're copying the profile, you're copying the contact. So that's the point. You want to make it in a way where it's so easy to copy that you don't have these mistakes later on. Like when I build composite restorations, I probably spend most time doing caries removal, which takes ages for me. And the other part is matrixing. The rest, I just kind of do it. I'd probably say on average, if it's a class 2, within maybe, you know, 7-8 minutes. But this part of the procedure takes me time because I want to avoid these things. And I've had them both, you know, so the point is take really, really careful care and actually make sure your wedge position is correct. A good way to check the seal is, sometimes it can be really difficult to see down there, but a good way to check it is take a probe and a sharp probe and just run it gently against this area here. And if your probe can obviously go through, that means there's not a seal there. Or if it kind of, you know, feels as though it hits the tooth and hits the band, again, you know, there's probably a gap. So those are some useful tips just to kind of work out, is there a seal or is there not?
Yeah, but I was going to say as well, if you have really good like high powered loops and lighting, you can see down there a lot better. If you're looking just with your direct or indirect vision through just with your natural eye, it's very difficult to see down there. So loops and lighting really helps in that situation. And then moving on to that middle picture, if you see where it dips inwards, your composite's going to follow that area of that band. So there's going to be a big void at the cervical portion where food's going to get stuck. Loads of stuff's going to get stuck. The patient's going to complain of food trapping. Even if you have a nice contact point, the area underneath is going to cause a bunch of problems. So you want to, as Bal says, just take your time on this bit, making sure everything's done properly.
Yeah. So a lot of people talk about things like, you know, pre-wedging and stuff like that, which we're going to go into in a second as well. But I've got these photos from Style Italiano, which is a really, really great resource for everybody to check out. You know, it's free of charge, and they have so many articles that kind of have photos plus text, so you can really get an idea of, you know, all the different types of topics from composites to onlays and whatever else. But one of the really, really useful things that I've picked up from, I guess, Style Italiano is effectively kind of modifying wedges. So what I tend to do is, again, we'll go through this in a second, is pre-wedging. And there's so many benefits of doing that. But the point is that whilst you actually modify your wedge, it means that you can get a custom wedge for that particular scenario, because each tooth, obviously, for example, here, you can see that, you know, it's quite a low cavity in terms of it's near the gum. So you might need a bigger wedge, but if, for example, your cavity was here, you might need a thinner wedge. So the point is that you can modify the height of the wedge, the thickness of the wedge and stuff yourself, and you can do that with things like burrs, and you can do that with things like scalpels and stuff like that. So you don't need to think that you need all the kit, all the different sizes of wedges. You can kind of get away with some of the just, you know, routine generic stuff. So that's quite useful. So pre-wedging, what is it, and kind of what's the benefit of doing it? So pre-wedging is basically before you start, let's say a class 2 or even a crown prep, for example, you basically put wedges in between the teeth after isolation. So for example, here, I think I was doing a crown. This was a root treated tooth, if I remember correctly. And it basically was going to be prepped for, I think, a venale or something. And we pre-wedged first. And the reason I did that was, number one, it gave a slight amount of interproximal sort of force to separate the teeth. So, you know, just a minimum amount of force or pressure so that the teeth can be slightly separated. And that means that when I cut the contact point, for example, it's just going to give me a little bit of space to work with so I don't or reduce the risk of damaging the adjacent teeth. And the other thing is that it really does help protect your rubber dam, especially, you know, when you start getting deep closer to the dam, to the sheet, because that's where your burr can sometimes catch it and then you rip your dam. And then once you've ripped your dam, you either think, okay, you either have to change dam, or if you don't, you go to a split dam. And, you know, let's say if you're doing things like immediate dentine sealing, or you're doing a composite where you need moisture control, you've kind of compromised that. You know, it might just make life harder for you. So pre-wedging is super useful because it, number one, separates your teeth slightly, ever so slightly. And number two, it protects your dam at the base, which is super, super useful. But the other thing that's really useful about pre-wedging is what you're going to see in a second is the middle photo. Yeah. So you can see these are two, again, these are photos from Style Italiano. But you could see that they've pre-wedged, and where you kind of see the lighter texture on the screen, that's where the burr has run over in terms of, you know, when you're removing caries, when you're separating the contacts and all the other stuff, they've run the burr over there. So that means if you look at the lateral profile, there's a slight modification of the wedge in that area, right? And that's the burr shank. So that basically means now when they put the matrix there, that's going to be the ideal wedge shape, and it's modified. So a pre-wedge isn't just about protecting the dam and stuff. It means that you're basically creating the ideal anatomy for that particular tooth based on the cavity shape. So I'd strongly recommend it, because like I said, it just basically means you get these ideal scenarios for your final restoration. Now, in terms of how to modify it, again, this is an anterior case. You can do it there as well. This is what the guys over at Style Italiano actually taught us. That, you know, you can just actually get a cigar cutter from Amazon, and it works really, really well to modify your wedges, because it basically means you get really fine control, and obviously it cuts them quite easily, and it's obviously quite sharp. But the other benefit of doing it anteriorly, which is more important in my opinion, is when you're working anteriorly and you're kind of, you know, taking really good care to get good aesthetics, the wedge can sometimes interfere with your matrix placement, or it can, because obviously the wedge is quite long, right? You only need the wedge for like a small amount of area. And if your wedge is long, sticking out, it can actually interfere with your matrix, or it can interfere with your placement of the composite. So I actually try and reduce the amount of interference by just cutting the wedge. So that way, when I work, there's nothing in my way. I have easy access, I have perfect vision, and I can actually move my hands quite freely, and there's no interference from a wedge. So in terms of class 2 cavity, so we'll just run through some cases very quickly. And like I said, this isn't to kind of teach you guys or you know, say how to do composite. It's more just to kind of, I guess, give you an idea about some tips and tricks that work quite well in our hands that we found anyway. So in terms of class 2 composites, like we said before, you obviously, you obviously do your isolation and your caries removal. But then you're going to need to do your matrixing. So like we said before, you take your sectional matrix and your wedge, you place the two down, and then you obviously put your ring round. The darker blue ring, in comparison to the lighter one, the darker ones, the forcep kind of legs, if you like, or the tongs are quite, you know, closer in. So it just means it's good for narrower teeth like premolars, whereas the other one isn't for larger teeth. So anyway, you do your proximal wall first. So you can see we've just built up the distal wall, and we don't remove the wedge. The reason we don't remove the wedge is because at this point what you can do is get a little bit of bleeding, because obviously the wedge is putting force on the gums. So if you remove it, you get bleeding, it compromises your moisture. So we leave the wedge in place. And then what we do at this point is we actually take our mirror and we assess from the buccal and the palatal or lingual, depending on if you're working on the top or the bottom. The reason you do that is to make sure you check your contact profile, your contact point, and make sure at this point if you're happy with it. Because if you're unhappy with it, it's quicker now to just take that bit of composite away, like drill it off and redo your bonding and redo your composite, than to do the entire thing and then have to realize at the end that the contact point is off. So that's what we do first. And then we just build it up. And, you know, I guess in terms of whatever technique that you tend to use. So for us, we don't try and really do bulk fill. So we do just kind of, you know, normal 2mm increments. I tend to use kind of a dentine replacement first. So that's going to be Everex or, you know, a type of dentine composite. So a fiber reinforced composite. And then I will top off the final 2 layers with an enamel replacement, just because, you know, I guess you have to kind of, I guess, respect what part of the tooth you're working in for kind of, I guess, the biomimetics of it. And then at the end, you just check the occlusion. Now, the key for this bit is that the occlusion, in terms of the marks, are not on the margin of where the tooth and the composite meet, because like Kris said earlier, that's the weakest point, or that's the most vulnerable point. And then essentially you just kind of, you know, I guess, polish it up and send the patient away and it should be fine. But you can see that's where the gums are obviously a little bit sore because we've wedged and we've done obviously some isolation with, you know, floss ties and whatnot. And that's why it's a bit tight there. And obviously there's a black triangle and that should fill by itself and the gum will heal and that should be absolutely fine and cleansable and it shouldn't be any issues. Well, there aren't any issues now. It's been about 2 years, so hopefully it stays like that.
Just that in there about using the dam as well will hold that papilla down a little bit, more so anteriorly, but sometimes a little bit posteriorly as well, or hold down and compress that area of gum, meaning you can get a better emergence. But when you take the picture, it will be still a little bit compressed, which is why there's a little black triangle there. That'll fill in.
Perfect. So Kris, do you want to run through the stamp?
Yeah, of course. So, sorry, let me just get to the point. Perfect. So, yeah, so the stamp is a really quick and easy way to kind of recreate the natural morphology that the tooth will have. So it's appropriate in cases where the tooth isn't cavitated yet, or there's a tiny little cavity. And can we go to the picture as well? Perfect. Yeah. And so a case like this where it's hard to tell from this picture, but there's not a cavity there. It's just kind of early uncavitated caries. So what you want to do is you want to just take a little, like take a micro brush, looking at that last picture on the right, and just place it over the tooth. Put a little bit of flowable over the tooth, cure the flowable, put the micro brush over that cured flowable on the tooth, and add a little bit more flowable so that the part that's bonded to the tooth bonds to the micro brush area. Cure them both together, and then it will just pull off in one piece, like you see in the bottom left picture. Then you do your cavity prep as seen in the top middle picture. So remove the caries, clean everything out, and then you place your first increment of filling. So you do the bottom kind of 2 millimeters and leave about 1.5 millimeters for your top layer. Then you fill the top layer with your enamel shade. Put a little bit of PTFE over the prepped surface of the tooth. Pop that micro brush down in over the PTFE, and it will recreate the anatomy nicely. You can take it off, just scrape off any excess, and then cure, and you get kind of an exact copy of what the occlusion was before in the pre-op situation. It's a really easy, efficient way of doing a simple occlusal if it's not cavitated yet. And even if there is a small cavity, you can still use the stamp technique and just run over the fissure pattern with a straight probe prior to curing. And it saves a lot of time. It's a really efficient way of doing things. Yeah,
for sure. I think the stamp technique, for me anyway, it always used to feel like it was a bit of a cop-out, because it's just like, you know, an easy way to kind of get a good result. But I think you realize that, you know, it's so much easier, more comfortable for the patient, because you get the occlusion spot on. They're obviously, you know, already used to it because it's a natural tooth or whatever. And you can even use this for class 2 composites. You do the exact same thing that Kris just said. So you copy and paste effectively The only difference is that you're going to do the freehand proximal wall. So you just build that up yourself. And once you've done that, you literally do what the photos on the screen say. So the bit that Kris was mentioning at the end, which is where you place a layer of PTFE over the tooth, and then you basically put your flowable resin microbrush and press down, is because what you don't want to do, if you don't have that barrier of PTFE, it will bond your microbrush to your tooth and it basically all fails. So you obviously have to make sure there's a separator, which is what the PTFE is for. So that goes as a blanket over the tooth with composite uncured, and then you press down and that basically imprints your anatomy into the tooth. You ligature and clean up. It's a really straightforward and efficient way of doing it. But like I said, it's yeah, it's a really predictable way of working. Anyway,
Matthias just asked if we place anything over the tooth surface before the flowable. You don't need to place anything. You literally just put the flowable straight on that tooth. You haven't put any bond, so it's not going to stick. It's going to come straight off as long as there's no undercuts. If there's any undercuts in the tooth, you run the risk of, when you try and pull, it's just going to get stuck, because it's all, the composite itself is bonded together, but it's not bonded to the tooth. So if you run over the bulbosity of the tooth, you're not going to be able to get it off in one piece. So you just want to kind of make sure you cover the whole occlusal surface without going too far down the sides.
Yeah, absolutely. So now, deep margins. So again, this is one of the biggest challenges that we have on a day-to-day basis about deep margins, how to basically, effectively restore these. And sometimes you think, okay, like I said at the beginning, you want to ideally use a sectional matrix band, but sometimes if you're, let's say, for example, we're doing a lower 6 and the buccal and the lingual area of the class 2 is quite kind of, I guess, let's say not enough tooth substance there. It means if you put your ring on, there's nothing for the tongs to hold on to, because the buccal and lingual portion is completely kind of destroyed because of the caries. So when we have cases like this, that's when we think, okay, we have to use an omnimatrix or a circumferential matrix because there's not enough tooth for the ring to stay on. So like I said, it's not ideal, but you can do it that way. But there are other ways to do it. And there's things like matrix within a matrix. So you use a sectional within the actual circumferential. Again, I don't think we're going through that today, but there's loads of cases we've got for that. But this is just an example of how we did this class 2 on a lower 6. So with this one, I couldn't actually put the ring on the tooth because the buccal part was actually kind of effectively completely destroyed there. So what that basically meant was when I put the ring on, it wouldn't actually have anything to grip, and it actually distorted and moved the entire matrix band. So I couldn't actually use it. So there's loads of different ways of doing this. This is just one actual example. So what I did here was I used a sectional matrix. So you can see the dent supply one, which is the V3 sectional matrix, and I used a wooden wedge. And I basically had a bit of a void because there was nothing, there was no pressure and there's little minimal tooth there. That's why there's PTFE there. So PTFE is so great as a material because there's so many uses for it. I use it for retraction. Again, you'll see some of this stuff in a little while, but I use it for pretty much most things restorative dentistry wise. But yeah, you just take a little bit and you just tuck it in there, and that put a little bit of pressure just around here where there is not as much tooth. That meant my band was sealed cervically. So right now, my main concern is the band sealed at the base of the tooth, because that's what this particular step is for, right? And it is. So what I did was I slightly built it up, and I just elevated it a tiny bit, right? So by elevating it, if you look at the difference between the two photos, you can see, number one, I'm sealed all the way here. So there's an absolute really good amount of, composite placed there, and there's still an open contact. But this area here is the key, because there's now more tooth there, or more composite anyway. That basically provides me with, I guess, something to position against my ring. And that's where that comes in. And then I re-wedge, put a new band through, and effectively I just do it as a normal class 2 composite. So effectively, these two are the main steps, because that's thinking a little bit outside of the box and then going to this. You can just kind of put a little bit of composite there and put it on again, or you could do a circumferential matrix. Like I said, there's no right way to do it. It's just something that works pretty well in our hands. And then at the end, you just build it all up, and then you check the occlusion. And again, thankfully, it's holding up okay. But like I said before, we use a lot of PTFE, and PTFE can be used for, like we said, you know, retraction. So that basically means like it can, you know, you can use it for as a retraction cord, which we do. We roll it up and we use it as a cord, but you can also use it to modify your wedges. So sometimes, let's say if you've got a huge, or you've got a huge cavity, or you've got a really big gap between your matrix band and your tooth, what you can do is you wrap your wedge to bulk it out or thicken it out a little bit in PTFE. And because the PTFE is quite, I guess, displaceable, if you like, it means that it can adapt a little bit. So it's quite kind of forgiving. So here, for example, you can see I was doing some onlays and I had a gap just there that I couldn't close with any other, well, I was trying so many different ways. I ended up in the end just having to wrap my wedge in PTFE, and it thickened it up a little bit. And then I just basically put it through, and that was what allowed this complete closure of this space. And like I said, that's the most important space. So this was a tiny bit of DME here, so a bit of elevation of the margin, and then I had to seal all of the dentines. That's why I'm doing this at this point. But again, the Teflon or PTFE wrapped wedge, super useful as a tip, because it prevents things like gaps. So I hope that was a little bit useful. Like I said, it was obviously for us to give you guys a rundown and a run through of some kind of scenarios that people most commonly struggle with. Like we said, you know, we're doing rubber dam as well, so we didn't want to take up too much time of the evening. So let's go on to rubber dam. So this is the kind of, I guess, generic stuff first, but I'm sure everybody knows this, and everybody probably uses rubber dam for things like endo and composites and stuff. But there's so many different reasons why we use it. So obviously, like patient safety, for obvious reasons, but patient comfort is a big one. So for me, I think a lot of patients that I'm seeing now, a lot of patients who haven't had rubber dam before, and a lot of people say to me that you know, they can't use rubber dam because their patients aren't used to having rubber dam from the previous dentist, and then that means that you just can't do it because the patients, you know, aren't up for it or whatever. I've been in that situation, and you know, there's certain ways to overcome that conversation. So for me, all of my patients have rubber dam. You know, even the ones that say that they've got, like, I don't know, asthma or whatever else, and they can't tolerate it. You know, there's a way to do it in a way that makes it comfortable for them anyway. So types of rubber dam. There's so many different types and thicknesses. I didn't really, I guess, appreciate how many different types there are and whatever else, but there's so many different types and so many different uses of each one. For me, I'm using mainly the medium one, as that's a medium thickness. That's pretty much my go-to. I sometimes use a heavy, and I'll explain why and when I use a heavy. But the medium one's a pretty good one because it's got enough forgiveness or enough sort of I guess flexibility to be, you know, on most of the teeth in most scenarios. The heavy one is really useful if you want it to hold its position. So let's say if you've got really subgingival, you know, isolation that you need to do, or if you've got, you know, preps like an upper central crown prep, and there's not much tooth and it's a bit subgingival. To make it go into that area subgingivally, the heavy is the one you need to go for, because the heavy has enough thickness to hold its shape in that area, and that's the key. So that's why I don't use heavy every time, but it is useful for those areas where it's super subgingival, because it holds its shape between the tooth and the gum.
Yeah, I also find, Bao, it's a little bit more forgiving. If you know, when you're using a light or medium dam, you can, when you're drilling in that area, especially with an air turbine, like a normal drill, you can catch the dam quite easily, and then it distorts, and then you get a cut, and then you get bleeding. The heavy kind of holds its place a little bit better, and kind of is a little bit more forgiving in that regard as well.
Yeah, absolutely. Yeah, I definitely agree with that. And I think I don't know what thickness I was using before, But I found when I was using wingless clamps and I would place the rubber dam over the bow, it would always tear. I think it was a thin, it must have been thin because it was like, you know, minimal pressure and it would always tear, and it was stressful. But the point is that just have a look at what thickness you're using. For me, isodam or kind of, I guess, the nick tone dams, the medium are the go-to. They're the best ones that I found in my hands. But yeah, have a try and see what you guys think, but check the thickness. Medium is the one that's pretty much good for most, if not heavy for certain scenarios. So common concerns, what happens with isolation? Like I said, we've had it all. You know, this is super like common, and for us, I don't think Kris and I have done a course on isolation or anything personally, but it all comes through practice. But you need to work out what's happening and why it's happening. So on the screen you can see so many different problems, right? So you can see basically number one, sorry, the resolution isn't great, but you can see basically there's gum showing between the rubber dam and the sort of tooth. So there's effectively, the point is moisture control. There's an area for crevicular fluid, saliva and stuff to seep through. It also means that it's not tightly sealed. So therefore, when you're drilling, the saliva, the water from your turbine can actually go through into the patient's throat, and then it means they need loads of suction underneath the dam, which delays the sort of flow and all that stuff. Again, you can see gum being exposed. Again, that's probably the most common one. And here you can see that it's folded, it's ripped there, and it's ripped there. Again, super common problems. And like I said, we've had it all. So, you know, these things, again, don't let them put you off, but there's ways to overcome this, which we'll go through now. So the first thing you need to realize and appreciate, right, is what are you actually, I guess, using each hole for in your puncher, okay? So the puncher obviously comes like with a turning sort of, I guess, you know, rotating wheel, and each hole is going to be of a different size. So this is just a general guide. Sometimes I don't use whatever's on the screen that you guys see. Sometimes I actually use, you know, I guess the really small holes for upper incisors. Again, it really varies. If I'm isolating crown preps and onlay preps and I'm bonding them under rubber dam, sometimes I'll use the first two or first three for a molar. Again, it just depends on the tooth, because each tooth is going to be different. Like some people have kind of really conical teeth, so they're thin, so you have to just adapt.
Sorry, but we got a question as well from Kieran.
Yeah.
Asked, would you use a heavy dam if the patient has large spacing between teeth to help with isolation? And to that, Kieran, what I'd say is the best thing you can do is, if you have a template, even if they have missing teeth, you can kind of work off your chart as to which teeth they have there and just punch those on your template, and you should have a rough kind of idea of where the teeth are going to be. But oftentimes they will drift a little bit or tilt and rotate. So the best thing to do is just, it doesn't matter what size dam you have, you can just take the dam, hold it up against their teeth and sort of make it taut as you would when the frame's on, and just mark the little, like the dots which on the teeth that you want to isolate, and then punch it that way. You've kind of customized your dam to that situation.
Yeah, we'll show that in a second as well. But that's effectively it. I think it depends. For me, if there's spacing between the teeth, I don't really go for the heavy dam based on that factor. I only go for heavy dam if it's super subgingival, because I want it to hold its shape. The key for me is if it's subgingival, the dam has to hold its shape between the gum and the tooth at the cervical area, which effectively means that there's no like matrix or anything to kind of be, you know, pushing the dam away in that area, right? So the heavy dam has enough thickness to hold its position there, whereas the medium one, if there's, for example, class 2 composites on a patient that's got massive spaces between their teeth, as long as I punch the right amount of space for the sheet, I shouldn't need to use a heavy dam. That's what I've found in my, you know, I guess somewhat limited experience anyway, but yeah, that's kind of it. So some tips on what we do is have a set sequence. So basically, for me, it becomes quite repetitive, everything in dentistry that I kind of do on a daily, just because it, you know, reduces the margin for error. You have a set sequence. So before the patient comes in, I effectively know exactly which tooth I'm working on, which teeth I'm going to be isolating, if I'm using floss ties or not, and I have it already pre-punched. So some really, really useful bits of stationery to get is a sharp tip, like Sharpie pen, or a fine sort of, you know, black pen or whatever, and a sharp rubber dam puncher that we just showed you on the previous screen. So this is probably going to answer Kieran's question as well about how to get the right space between the teeth. The key is use a template. Okay. Now, I know Kris mentioned that sometimes you can put the rubber dam up against the patient's mouth on the frame and actually just use a pen and actually, you know, put the dots on the actual dam whilst the dam's on in their mouth. I rarely do that now. I used to do that a lot. I rarely do that now. I just use the template. So a template you can get, you know, I'm sure you can actually print one from Google and laminate it, and then it becomes a template. So you can get one for free if you like. We are getting some made, some really high-tech version ones. So they're kind of, you know, a little bit more long-lasting. But anyway, the point is that you effectively have a template which has the ideal spacing between the holes. So when you actually come to put it on the teeth, it just pretty much means you have the right space between each tooth, so that the dam isn't kind of overstretched and stuff. And also it just means that, you know, it's really quick and easy to do because this stuff is all done before the patient walks in. So my dam is stamped, punched, it's on the frame, my clamps are ready, my floss ties are ready. It's all rubber dam for me. Should now probably take, on average, I'd probably say around about 45 seconds to a minute. But sometimes it takes longer depending on the type of isolation I'm doing. Like sometimes it takes me half an hour if I'm doing a subgingival prep isolation. But the point is that you want to make it quick and easy, and the only way you do that is by setting up in advance before the patient comes in. So, how many teeth to isolate? I think it's really useful to isolate as many as you can, just because number one, it gives you practice to do it quite quickly later on. So I was doing this during BT. I was isolating, you know, quadrants and stuff just for practice, and I had all the problems that I showed you at the beginning. I still do, to be fair, but the point is that you overcome them with time. So you ideally isolate as many as you can, and especially you want to isolate. Let's say, for example, if you're doing a filling on a 6, so a molar, you ideally want to isolate a tooth either side of that. If not 2 teeth. The reason is because number one, it gives you a little bit of, I guess, you know, location as to where you are in the mouth. It allows you to kind of copy the height of the adjacent teeth, so you get the occlusion right or roughly right. So again, you need to have minimal adjustments. It gives you an idea of where you, like I said, where you are in the arch. And it also means that, you know, you can obviously, let's say, for example, if you're doing class 2s, you need to have multiple teeth either side so you can get your matrix and everything down. Even if I'm doing a class 2, I rarely, unless there is no tooth, you know, behind the tooth I'm working on, I will always clamp behind the one I'm on, just because when you have the ring and you have the clamp and all, you know, you have your burrs and everything and instruments in that area, it can get quite crowded. So you want to give yourself a bit of space. So isolate beyond is my advice. So just some general tips. Have a really sharp rubber dam puncher. That's the key, right? So the puncher is this kind of triangular sharp point that I'm just going over now. Now, if for example it's not new and it's old, you can just take a burr. Kris told me about this tip actually. You can just take a burr and you can just sharpen it up, and you can basically make it a little bit pointier so that when you punch your dam, it goes through completely to give you a completely uniform hole. And
be really careful with that as well, because you can mess it up as well quite badly. So just be really careful. Use like the finest burr you have, or a white stone or something, and just polish it up a little bit, really carefully. Because if you mess up, you're gonna have to buy another one probably out of your own pocket.
Yeah, that's probably something I should have added on.
Disclaimer,
yeah. So some tips to kind of get some good rubber dam isolation. So the key is once you punch your rubber sheet through the actual force, the puncher or whatever you call it, you have to push the sheet away from the hole. So you can see this is where this is the biting point. This is where it's punched, and look how far we've pushed our sheet away. That way it completely pierces the rubber dam, and at the end we get a completely uniform circular hole. We don't get any of this stuff, right? So this is just a very basic drawing that we found on Google about, you know, rubber dam isolation and stuff. But you can see you want that circle. You don't want this where you got a little area in the within the hole, and you don't want a little rip, because that area is now going to mean when you stretch it over the tooth, there's a gap there and saliva gets in. And this is always kind of a little bit of excess dam that you haven't removed. And sometimes when you try and pick it out with your fingers or tweezers, you end up ripping it and you don't get this hole. You end up with an even bigger hole that's even worse off. So the way to get this hole always is to do this. Punch it with a sharp puncher and pull the sheet all the way away from the biting point. So you pull it out away, and that way you've got a completely circular hole. And this is what it should look like at the end once you've done your punching. And you can see all of those holes were done, you know, literally, as in how long would it take you to do a few holes, but make sure that they're bang on and they're always circular, completely uniform, because you want it to hug the teeth and make sure there's no gaps.
Yeah, I'd say as well, if you notice there's a little tear in it, just don't waste, just throw it away and just start again, because when you go to stretch over the tooth, it's going to tear. It's going to waste more of your time. So if you haven't got a perfect circle, I'd say just what I personally just throw the dam away. And then like the root canal guy at my practice told me that if you've got a perfect circle in your rubber dam, it will stretch over your head apparently. So it's really, really strong. If you've got a perfect circle, it won't tear. But if you do have little stress points or little like any areas where it's not a perfect circle, it's going to break. So just throw it away.
Yeah. So the reason to use a template, right, is that you can actually get the right space between the holes. So if you look in the photos here, what Gov is showing is that basically if you have excess rubber dam between the holes, you get folding up, and that then means that you get, for example, you know, if the holes are too close, it just means that there's not enough space between the holes or the sheet, for example, to kind of go invert and, you know, completely stretch. Because there's too much pressure here, it's having to fold over itself, so you can't really invert it. And let's say if you're doing a deep class 2, that means that the dam there is going to be a bit folded, so you can't really get complete isolation, whereas here you can. So try to make sure that you have the right spaced holes, and the best way to do it is either using a rubber dam template, which for me works most of the time. For certain specific cases where you've got a lot of crowding or misalignment, you might need to obviously use what Kris said about putting the rubber dam in the patient's mouth, unpunched, take a pen, and literally just stretch it over the teeth that you're looking to isolate, and just put a dot on the occlusal surface of each tooth that you're isolating. That's your custom template, if you like, and that gives you the absolute right space between each tooth. I don't like doing the stamp. I know a lot of companies and a lot of people like to stamp the rubber dam. I just find that the ink goes everywhere. So when you actually start using the rubber dam, unless you've stamped the inverse side or whatever, the opposite side, it just means there's so much ink everywhere. But I guess it must depend on the type of ink that the stamps are and all these other factors. But for me, I just don't like it. So I try to use the pen and the Sharpie or whatever. So clamps, loads of different clamps. You know, again, there's probably not enough time to go through everything today. So we're just going to kind of run through a few little basic bits. But you know, there's no right or wrong. People can use winged or wingless. I use both, you know, just whatever's, I guess, more available or easier, to be honest. I tend to use both. I was going through a phase where I was just using winged, but now, again, I'm just using wingless. So I don't think there's, you know, a for or against it. But in terms of clamps, like we said, there's so many different types. So the soft clamp is a really, I'm quite actually liking this clamp lately. I never used to use it until kind of the last maybe 5 or 6 months, but it's really good for second molars, just because you can see it's kind of like got really, you know, close sitting tongs, if you like. So second molars can sometimes be quite small. Second upper molars anyway, they can be quite small. So this clamp tends to really sit well on the tooth. And also because it's soft, it doesn't really, you know, traumatize the gums too much as a metal one can. And plus, because it's got wings, so wings are these portions on the outside surface. What they do is it basically means that, number one, you can put everything on together. So when I actually use this type of clamp, I put my clamp, my dam, and my frame all on in one go. So it's a 3-in-1. It just makes life easy. And then I just take a flat plastic and I just literally release the dam away from the wings, and it just sits in. And that's effectively my isolation done once I've flossed it through. Yeah, and
sorry, just adding on to that, what I'd say as well is, if you are doing the, like, using a wing clamp and getting it all on in one go, what I personally would do is, just before you put the dam on, just try the clamp on the tooth just to make sure it's sitting properly and that the patient's numb enough, because you don't want to get to the point where you put the dam on and it's a bit awkward, it doesn't fit right, or it's rocking. So just check that your clamp's the right size for that tooth, especially when you're doing big second molars, which sometimes aren't perfectly kind of shaped for the clamps.
Yeah, so the wingless clamp, so like I said, this is one of the ones that I'm really using most frequently now, from the winged, from what I was using before. I quite like this one because the W8A is the one that I probably use a lot, or the B5, is just because of, number one, it's got, you know, very small kind of, I guess, feet of the clamp, if you like, so it doesn't really interfere much with anything outside of the point that you've isolated. So it's quite nice, because it means if you're putting a matrix band, or if you're putting a, you know, let's say, if you're doing a prep and you need your bird to go around that area, you can prep under rubber dam and it doesn't interfere much, which is really good, but it is stable enough to hold the dam down. And this is a really good clamp, which is really useful for isolating teeth when you're doing distal fillings. So you can see it's got kind of extended legs here. And what that does is that you can actually kind of use it to, let's say, on a premolar, but it can isolate all the way back to a upper 7. So that way you can actually do a distal occlusal filling on an upper 7, but you're not clamping that tooth, because this is clamped on the premolar anterior to the area that you're working on. But the legs of the clamp, because they extend beyond, they hold the rubber sheet down to make sure that you still have isolation, plus you can access the tooth that you're working on. So this clamp is a really good clamp. And you guys might have obviously seen additional clamps. So these are things that are like, so what we just spoke about now were what we call primary clamps. So these are clamps that are used to hold the rubber sheet down. So they're very strong, they're very firm, and they make sure that the rubber sheet doesn't obviously ride up or whatever. The Brinkers, or the additional clamps, these are supplemental clamps that you use for certain areas that you need further isolation. These aren't strong enough to hold the dam down by themselves, so you need to use this with another clamp. So the Brinker is the B series, from B1 to B5. I think it goes up, maybe it goes up more, I'm not sure, but essentially it's a great clamp for isolating preps and subgingival margins, which we'll show you guys in a second. Because again, this is us actually pulling the B4 out, so you can see even then there's not much space. But if we relax that clamp, it relax the forceps, there's literally virtually no space between these two legs of the clamp. So it's really good for that. Yeah, so clamp choice, how to choose the right clamp for the right tooth. So the key to it is 4-point contact. So that basically means that the clamp needs to contact your tooth in 4 separate points to make sure it's stable and it doesn't rock or it doesn't come off. Because what you don't want to do is have your rubber dam being placed on an unstable clamp, and as soon as you place the rubber dam on, the clamp can, come off the tooth, or it can even fly off outside of the mouth. That's happened to me once, where it actually flew off outside of the mouth and about, a couple meters away. So, these things can happen just because you're not choosing the right clamp. So like I said, all this stuff has happened to me. So this diagram is really useful because it kind of tells you what's what. But the key is we've deliberately done a right and a wrong on the model that you can see. So the left picture is an oversized clamp for a second molar, and you can see, if you zoom in, or if you can see a little bit clearly on your screen, that the clamp is way too big, because if you look in the mesial portion of the tooth and the mesial portion of the clamp, there's no engagement of those two tongs on the mesial aspect. It's actually sitting on the gum. So effectively there, you've chosen the wrong clamp for that tooth. So it's just not going to work. Whereas if you look on the other photo, you can see there's 4-point contact. It's the right size for the right tooth. It effectively is a stable clamp, and there is no gum showing, or there is no sort of area where you're going to get leakage. So this is the key. Choose the right clamp the way you check it is 4-point contact. Sometimes if I'm ever unsure, I just have 2 or 3 clamps ready on standby, and I just try and see which one's the best fit and take it from there. So how do we place the rubber dam? Again, there's no right or wrong way to do it. We're just going to show you what works for us in an efficient and reproducible manner. I think that's the key for what we try and preach at Kaizen. It's got to be efficient, it's got to be effective, and it's got to be predictable. So what I tend to do if I'm using a wingless clamp, so that's the one that we just saw, there's no wings, is I will, like I said, before the patient's even walked in, the frame is on the rubber sheet and the teeth are already punched. My clamp is already waiting, and effectively, you know, all I need to do is numb the patient up and effectively get started. So I have it ready like this. So I put the frame on the rubber sheet because I like a little bit of tension on my rubber sheet. So when I'm putting it over the bow of the clamp, there's a little bit of tension for the sheet to stay in place. Otherwise it gets really fiddly, and I feel in my hands it just goes everywhere. So I like to use the frame on the rubber dam. So like I said, the wingless clamp is on the tooth. And what we do is we guide the actual rubber sheet over the bow of the clamp. And then that sits on the distal aspect. And then we start to slowly just kind of orientate the holes over the occlusal surface of the teeth, right? When we're at this point, there's always, most times, a bit of gum showing. Here there isn't much gum, but there's always some gum showing here. Now, this is where you have to rock the clamp, and you have to kind of slightly just disengage and re-engage the clamp, which we'll maybe go through later on. But the point is that that's not your concern right now. First, stabilize the entire rubber dam. So go over the bow, then you need to line them up so that you're kind of roughly in the right area. And you can ask your nurse to help you with this, but with me, I do most of it, most times, unless it's a complex case, like most times on my own, just because the frame helps give me that enough tension for me to do it with just 2 hands. So you can see this is just the frame holding that in position. Then what you do is you actually start to floss through the actual contacts. So you're gently lining everything up. This time you can ask your nurse to kind of help out. So your assistant can gently put their finger here or here, just to provide enough buccal and palatal sort of, I guess, you know, tension on the rubber dam. So when you floss, you don't rip the rubber dam, or, you know, it just kind of gently flicks through. And then what happens is the rubber dam will just gently, literally go all the way through, and you can start seeing how it's going to, you know, gently take shape. Then once the rubber dam's on, now we want to try and actually make sure it's fully seated. So for us, what we tend to do is we take some floss and we actually try and follow the gum architecture. So that means the gums are obviously inverted V's, right? Or upside down V shaped. So what we want to do is take the actual floss and follow the actual rubber dam along the gum line. So you're going down so that the rubber dam follows your floss and it tries to invert itself. You won't get it completely inverted all the time this way, but you'll get most of it done. So you can see there's not inversion because it's a little bit of overlap. Here we're going to need to do some adjustment. So that overall is pretty good so far. Now, how do you get complete inversion though? So do you ever get these areas which, you know, sometimes they might not be important if you're doing, you know, a class 2 here, but if you're doing a prep or whatever else, you might want to just get rid of that. And the way we do that is by taking a flat plastic and a 3-in-1. What we do is we gently blow a little bit of air, so your assistant can blow a little bit of air from the 3-in-1 tip, and you take a flat plastic and you just gently tuck in those areas that are slightly folded, and that will then just obviously ride down and tuck into the gingival sulcus along the gum line, and you're done.
Yeah, the reason it won't invert in those areas is because the gum's quite wet and it's very slippery, so the dam will just keep popping out if you try it without the air. The air will give you enough kind of passive like force with where it's blowing, and it will also dry out the gingiva a little bit, so the dam will sit in place, and then once it's there, it will stay in really nicely.
Yeah. So Brinkers. So when do you use a brinker? So like we were saying earlier, a brinker is an additional clamp. It's not a primary clamp, so it's not strong enough to hold your rubber sheet down. It's an additional clamp, so it's something that you're going to use to maybe isolate complex areas or preps, or let's say buccal cervicals. So this is where we tend to use brinkers. So we're fitting an Emax restoration. So for Emax, it's bonded in, so that means isolation is super important. So what we tend to do is we will use a brinker in certain situations where we need to isolate the prep because the rubber dam is riding up. Sometimes there's not enough tooth structure around, because obviously you've done a prep, so you've effectively reduced the height of the tooth. That means there's not much to hold the rubber dam down. So a brinker provides additional support just to hold it down. So you can see here, I've actually clamped this tooth. So this is a 6, I've clamped the 7, and I'm using a brinker, and I have to fit in that area. So it's quite claustrophobic for working, but sometimes, rarely you might need to do this. This photo here, this tooth is effectively probably like 1.5 millimeters tall. So it's super short at the gum line. And you can see how much retraction and how much isolation we've got. So, they are super useful. So just make sure you don't use this as your primary clamp. So you've got your primary clamp there, and this is just for the area that you're working on.
I'll just quickly, we've got a question at the bottom about the B clip. If we go back to the last slide. Yeah, so basically the B1, 2, 3, and 4 are for, they're your primary clamps. It's the B kind of 5, I think 4, 5, and 6. The thin ones are the accessory clamps. The other ones, the 1, 2, and 3, they're actually the primary clamps. I know that it's a bit confusing because they're all called brinker, but the ones that are kind of accessory clamps are the really thin ones that will sit on the root. I don't know if we've got any pictures of them in this PowerPoint, but
no.
I think it's 4, 5, and 6. I'll just quickly find out now.
Yeah. So the series is basically the way to tell which one's an additional brinker, which one's an additional clamp and not a primary clamp, is you can tell by, number one, the distance between the sort of legs of the clamp. So they're really close together. And the second thing is that if you actually look at the thickness of the clamp, is quite thin. So it's quite flexible if you move it with your fingers. So that basically means that it's not strong enough to hold the dam down itself. Whereas this clamp is quite thick. And if I show you the occlusal view, if we have one, you can see that the actual the legs of the clamp are quite firm, and this you can't move with your fingers. Like you can't actually bend the metal because it's quite thick. So therefore it's strong, which means the rubber dam can be supported. Whereas this is completely opposite. It's not strong enough. I hope that answers your question there. So summary of placement. So how do we do it? So if you guys want to screenshot this, feel free. But essentially what we're doing is we are giving local. We then, obviously, this is before the patient's even in. We've used a template. We've had the rubber dam prepped. We've got the holes punched. We've got the clamp that roughly we know we're going to use, or we've got 2 or 3 that we're going to use. You can floss the contacts whilst the numbness is kicking in. So that way you can just kind of open up the contacts, get rid of any food debris or anything like that, or just kind of open them up slightly by flossing them. Then you place your clamp on if you're using a wingless. If you're using a winged, obviously you have to go, do the dam and the clamp together. You can do it without, you can do it, sorry, the dam and the frame together and the winged separate, but again, there's no right or wrong. Stretch the dam over the bow, and that way it should seat down. And then just place your frame and kind of, you can actually trim it away from the nose, so that way it's comfortable for the patient. What I tend to do is also take a cotton wool roll and I place it between the frame and the patient's cheek. So keep an eye out for this if you haven't noticed it, but I picked this up from my nurse because she obviously worked with another dentist in the clinic who she must have picked this up from. But what she did is when I had the rubber dam on, she realized that it kept hitting the patient's cheek on the side it was clamped. So if I was doing an upper 6 on the left side, the left side of the frame would always go really close to the cheek, and it would leave like a red mark at the end of the procedure, just because it would be pressing against the cheek for like an hour. So she would take a cotton wool roll and just basically put it between the two. So put it between the cheek and put it between the frame, and it just cushion it, so it was just more comfortable. So that's a really, really good tip that she taught me. But yeah, then you obviously want to place it over the most anterior tooth and flush it down, and then make sure you rock the clamp. This is so, so important. Rocking the clamp is basically where you take your finger, and what you do is you go to the bow of the clamp. So the bow obviously is this area here, and you place your finger and you press down on it, and you move it a little bit left and a little bit right. And that way you just make sure that it's fully engaged. If it's not engaged, when you rock the clamp, it will move. And that means that you've either not engaged it properly on the tooth, or you're using the wrong clamp. So you need 4-point contact. If you've got 4-point contact on the tooth and the clamp, when you rock it, it won't move. So the other bit that I was going to mention before we go into floss ties is sometimes we use a little bit of PTFE. So I remember this case, I was fitting some onlays, and I had a gap between my rubber dam and the tooth. So there was a small bit of gum just showing through there. And as I was looking at it under loops, I just saw that there's always a little bit of saliva seeping through. Now, if I'm doing onlay preps, onlay fits, you can actually kind of see it there a little bit. If you're doing onlay fits, you don't want that. Obviously, you want as best isolation as you can. So I used a little bit of PTFE tape, and I rolled it up into like a sausage, and I just tucked it into this area here that was exposed. And when I use PTFE, because sometimes when you're tucking it in, the actual flat plastic or the probe or whatever you're using, it can stick to the PTFE because of the sort of, I guess, texture, or the I guess maybe the static or whatever else it is. So I just gently wet it in a little bit of water. I just dip the flat plastic in, and when I actually tuck my PTFE in, it doesn't actually come back and doesn't follow the flat plastic. So that's, again, a useful tip that should help to get isolation like this. So we're coming to the end of it now, so there's only a few slides left. Floss ties. So floss ties or floss ligatures, these are super, super useful. The point of these are to basically reinforce your rubber dam isolation cervically. So if you're working on, let's say, deep margins, or let's say anteriorly when you want to put some matrix bands or whatever else around this area, a floss tie is going to be super useful because it basically pushes your rubber dam up as high as it can be, and it keeps everything nice and tight. So we'll run through how to do one, which hopefully is useful. This is a video that should play in a second. There's different ways to actually do a floss tie, so we're just going to show you the two different ways that we commonly use, and then, yeah, feel free to ask any questions. So it should just play, and I'll try and narrate over it. So you want to probably take a fairly long piece of floss. I'd probably say about 30 centimeters or so, and you want to, this is the self-ligating knot, which basically means that the knot will tighten itself by just pulling it. So the first thing you want to do is take the piece of floss and do a bow, which we've just done. So it's like a little hoop, and you want to do another bow, so the exact same thing. So you do a bow, and now you've got two loops. So you'll see in a second when my thumb comes out, it tightens up into a little knot. And now, if I pull on that long piece, it will start to tighten itself. So if you imagine my fingertip is the tooth, you can see me pulling with my right hand tightens the actual floss tie. So that way you can actually just place the floss tie over the tooth, and you can just pull, and it will basically just tighten over the tooth. This is go on.
Sorry, but I'll say we'll put. I know this type of thing, you need to see it a few times for it to make sense. We'll put it on our Instagram story so you guys can watch it and just try yourself tomorrow in clinic, so that it's a bit easier. It's one of those things that once you got the hang of it, it's really easy and it's second nature, but it takes a little bit of watching and trying to get used to it and just get that muscle memory going.
Yeah, for me, I think it took me ages to really comprehend what was going on. So I had to watch it so many times and pause it at different points and then try and memorize it and stuff. But you get there in the end, just try and press it up. Say again?
No, I just said we'll put it on the Insta on our Instagram story so everyone can just keep rewatching.
Yeah, perfect. So this is the other way to do it, which is a this is the single knot. So this is another way to get a floss tie going, but the only difference is that this isn't self-tying. You'll see what I mean by that in a second, but the first one I just showed you, it basically means if you pull the strings, it will tighten itself. This one doesn't do that. This one you have to actually pull each side of the floss yourself and tighten it like a normal knot would. So it's a bit easier to tie though, so it might be easier to start with this one. So you take the same amount of floss, so about 30 centimeters worth, you fold it in half. And then what you do is you take your first finger, so your index finger, and then you open up your other two fingers and you just do a little loop. And then you reinforce it with your thumb and just pull it through, and that's it. And then release your two fingers away. So those two fingers should come out, and then you tighten up. And now that is a little floss tie, but that's a single knot. So that means if I pull with my right hand, it's not going to tighten, so it's not tightening there. But if I take both hands and I put on each side of the floss, it will tighten. I sometimes use this one. It just depends on the type of, I guess, case I'm doing really. But again, the point is that there's so many different ways to do the same thing. So again, we'll put that up, and that's a little bit easier to get started on if you want. So one last video before we start finishing up, but you can see how it works. So this is just sped up a little bit. So we've already made a floss tie. We've done the self-tying one, but you can see you put it on the tooth. So you guide it on and effectively you just pull, and my right hand will start pulling and it just ties itself. And you can see it's a self-tying one, and then you just cut it off. Yeah. So a lot of people message to ask us about floss ties and the fact that they will ride up palatally, and they always found that on the buckle they'll get a good isolation and a really good seal of the floss tie, but on the palatal or the lingual it wouldn't sit against the actual tooth, or it would just kind of, you know, it wouldn't just isolate. So this is a way to overcome this. Yeah, so you have your isolation ready. The floss tie, you basically will do your whatever knot you're going to go for. So in this case, we've done a double self-tying knot. So the first video. Now you take some tweezers, or you can use your finger and thumb here, whatever you want to use, and you basically guide it, the loop, over the tooth. So you go over the tooth, and you can see that we're putting pressure here and here, and this is going to just floss through. Once you've done that, you start to slowly release this area here, so it starts to sit around the tooth, and then you start to pull here so that you start to bring the knot in, and you can see it sitting closer to the tooth. Now, between this photo and this photo, if you just left it and let it tighten itself, it will want to ride up, because the way you tighten it will you're pulling on the tooth, it's going to try and come up and away. So you take the tweezers or a flat plastic and you press down and hold that area down. So whilst you're tightening at the same time here, you're pressing the forceps, or you're pressing the tweezers down. This is going to stop your floss tie on the palatal riding up. So it holds it and reinforces it. Then you get to this point and it's already all seated all the way around and it's not riding up there. Then you get to the tooth and it's tight, and look how tight that is. As in, you can't even see it because it's so tightly against the tooth. Once you've done that, you just cut off the excess, and once you've cut off the excess, you obviously have complete isolation on that one tooth. And again, you can see from the buckle all the way through, it's isolated, and that's effectively how to do a floss tie. I think that is pretty much it. So we hope you guys found it useful. I don't know if there's any questions, but you can obviously let us know. But yeah, that was effectively a whistle-stop tour through rubber diamond composite.